Although it's not the happiest topic, as women and mothers, we need to know what can happen in our bodies. So today's episode is all about the possible causes of first trimester bleeding. Dr. Leah and I break down 10 potential causes, ranging from spotting to a very heavy flow, so that you can be empowered with knowing the difference between benign bleeding and then that which may be threatening to either you or your baby's lives. We discuss implantation bleeding, chemical pregnancies, ectopic pregnancy, threatened miscarriage from low progesterone, molar pregnancies, subchorionic hemorrhages, and more. Let's dive in.
Welcome to Healthy as a Mother, the podcast for becoming and being a mother, with your co-hosts, Dr. Leah Gordon and Dr. Morgan McDermott, two naturopathic doctors who get it.
Each week, we teach you how to be the healthiest mother you can be, from fertility and preconception to pregnancy and birth prep, through postpartum and throughout motherhood, empowering you with the natural health guidance and education you're not getting elsewhere, so you can confidently navigate the broken system at large.
The real, the raw, the untalked about. And remember, this information is not intended to diagnose, treat, or manage any disease. Always consult with your doctor before making any changes.
The metabolic needs of pregnancy, postpartum healing, and making breast milk require more minerals than in other times of your life. And staying truly deeply hydrated during these times is very important. Nowadays, there are more options for this than ever, and ingredient quality and manufacturing integrity is very important for Dr. Leah and I. That's why we love Redmond Relight electrolyte powders. Mined in the USA, Relight contains Redmond's ancient unrefined sea salt with 60 plus trace minerals in addition to the appropriate proportions and forms of calcium, potassium, chloride, and magnesium that pregnant and breastfeeding moms need. Pregnancy demands a huge increase in blood volume and synthesis of an entire new baby, and that requires, you guessed it, minerals. This is the perfect blend to be sipping on during your labor or to have mixed into your bedside water bottle during breastfeeding. It tastes amazing, and my favorite flavors oscillate between mixed berry, strawberry lemonade, or lemon lime. Grab a sample pack option to try them yourself and use code HEALTHYMOTHER for 15% off your order of any of the products that Redmond has to offer, including their OG sea salt, other seasoning salts, natural toothpaste, bentonite clays, and more. Happy hydrating! Okay, so we are going to go through some of the most common causes and some more information around first trimester bleeding, because it can be very scary to see blood when you are hoping not to see blood during your pregnancy. And there can be a lot of different reasons for this. And so a lot of them are also within the realm of normal, and they don't necessarily mean that you're going to lose your baby. And so it's nice to know that, because I think automatically people think, this is it. This is the beginning of the end. And it's one unfortunate thing is that depending on how many weeks pregnant you are, like if you're very, very early, you may just have to continue to keep waiting and see. You don't necessarily get an answer. Even if you go get imaging, you go get an ultrasound, sometimes it's just too early. And so we sometimes with first trimester bleeding and pregnancy, often there's like a larger portion of unexplained bleeding sometimes. And it's just one of those many things along with pregnancy that is sort of a miracle and also sort of a mystery. And we just have to trust and kind of be like passengers on the seat of this experience. And I just want to give everybody a big hug if you've experienced it before, if you've had miscarriages, etc. It's really no fun, but hopefully we can just give some information that will help empower you or help you with teasing out the potential causes or reasons of why maybe you are experiencing bleeding in pregnancy.
Yeah. And one thing I just want to note is just because someone you know, a friend, a family member might have a type of bleeding, it doesn't mean that, like, let's say you experience that, it's exactly the same, right? Because there are so many root causes. There are so many things. So maybe your friend had bleeding and it resulted in a miscarriage. That doesn't necessarily mean that will be the case for you. So just know that it's important to have this information. And the thing that we've talked about so many times is in our conventional model, a lot of women just don't see their OB-GYN in like the early weeks. And so there is kind of this window where women feel kind of unsupported, unless you have a great primary who can see you and all of that. So hopefully this will be helpful to you guys.
Yeah, absolutely. Let's see. I'm trying to think. So let's share our own experiences. Have you ever had any bleeding in pregnancy?
No, because I've been pregnant twice. Well, I've been pregnant. Well, I don't think my failed transfer would, I guess you would kind of consider maybe that. I don't know. I don't know what that's considered when
Did you have any bleeding with that at all?
I don't think so. And then I never had bleeding, but I was on so much progesterone. So when I went through IVF, obviously we've already bypassed any chromosomal abnormalities because the embryos were checked. which is a common cause we'll get to. I was on progesterone and making my own, so that was ruled out. And then I just personally didn't have any of the other things. I had a polyp, but it was removed before I got pregnant. So a lot of my pregnancy, a lot of the things that could cause issues with bleeding were already kind of either dealt with, ruled out, or supported. So that wasn't my experience, but I have with patients.
What about implantation though? Did you get any? Is that a thing with IVF?
It probably could be. I never did though.
Okay.
Yeah. But I have had patients who have bled and has resulted in a miscarriage, and patients who have bled and we've caught it being low progesterone and resulted in a healthy baby.
Oh, yeah. We're going to talk about that too, because that is a really frustrating cause of, unnecessary miscarriage in that kind of a way. I have not had normal bleeding that I can think of. Except in the case of like exercise or sex, and then with like, your cervix being more friable when you become pregnant, that I have had.
You know what? I did have like a slight tinge of blood early on with this pregnancy.
Like just one day, like one time, or
what?
what?
It was like pink, it wasn't like bright red blood, but I did remember having pink a few days, in my early pregnancy, now that you tell me about that, because
Were you worried?
Worried. Yeah. Oh yeah, for sure. I mean, especially after coming out of a failed transfer, it's just like, oh my gosh, it's so hard.
It is. It can be so hard. When I started bleeding with both of my chemical sort of early miscarriages, I'll talk about what a chemical pregnancy is too. It was like the beginning, and then it never stopped, and it was like a large amount of bright red blood, and then it just like continued for days, and it was like a very, very, intense period, and lots of cramps and clots and things like that. But I feel that I was lucky in that it didn't tease me for too many days, because that can happen too, and it's really frustrating because you're like, what's happening? I don't know, but it was sad, obviously. But I actually noticed, I feel like what was probably my mucus plug on my first miscarriage coming out. This is like so TMI, but this is what we're here for.
Can a mucus plug happen that early?
Yes, it happens immediately.
Wow, I love that you know that.
Yeah, I went to go pee, and then I just felt something weird, and I looked down, and I had a long, 7, 8, 9-inch long string of like bloody mucus that was hanging out of me, and it like clumped into the toilet, and then boom, it was like blood. So I think that was probably, it wasn't the thicker type of mucus plug that you see at the end of pregnancy, pre-labor, but I was like, oh, that's not supposed to be happening. Yeah. What's that? And then, I mean, I'm laughing about it now. I was not laughing about it then. And I texted one of my friends who had 4 kids at that time, and she was like, maybe it's just a subchorionic hemorrhage, which we'll talk about, in the future here of this episode too. And I just knew like, no, this is not happening. And then with my positive tests, we're also getting lighter, and so that's a thing too. But okay, so the way I organize, I just wanted to tell our little personal anecdotes, because we do report, we hear feedback about the podcast that you guys like that you like our sort of personal notes. If you're looking for a really like just stagnant medical podcast, this is probably not it, because we're going to share a lot about our own personal motherhood things. So just getting that out of the way there. Maybe we're not your people.
Don't listen to us.
Don't listen to us. Go on. Bye. Okay. So I try to sort of order it in a chronological sense, like what would be the earliest forms of bleeding, the possible causes, and going towards the end of the first trimester. So point number 1, let's talk about, there's like 10 of them. So implantation bleeding. So a lot of times people can mistake their implantation bleeding as their period, because it comes around the same time. So it's like a, 6 to 12 days post ovulation thing. And that would maybe be right around when you are missing your period, or maybe a little bit early and if you have a lighter cycle too, it could be just enough blood where you're like, that was a weird light period. I don't know. Because there also can be a bit of cramping with implantation, because we have to imagine that this little cellular ball, which is like the blastocyst, your early embryo baby, is burrowing into the side of the uterine lining. And so that can cause a little bit of cramping, a little bit of bleeding, etc. And it's all very normal. But if you also don't notice implantation bleeding, then that's also totally normal. And many women don't. I would say most probably don't. But there can be that kind of like pinkish, as you mentioned, or brown, sometimes like a brown old looking blood. It can last just between like a few hours and then up to a couple of days. It wouldn't last more than that usually. It's not going to be like a heavy flow of blood for implantation bleeding. It's just going to be a little bit. And there's like nothing you do about it. There's nothing you can do about it. It's just a normal part of the process for some people. And again, a lot of people don't even notice it.
Mm-hmm. Yep.
Yeah. Okay. So then number 2 is a chemical pregnancy. So this is where you get a positive, you are pregnant, but then you either start bleeding or it becomes negative and then you start bleeding, something like that, usually around that 5th week. So it's like you're pregnant for 1 week.
Yeah.
Because technically, well, you're pregnant for 5 weeks, but you've known that you're pregnant for 1 week because you've missed your period. And so it's called a chemical pregnancy because it's like probably in the situation, if they did some imaging, the baby maybe the sac didn't develop properly, or it was something like a blighted ovum, or, it wasn't able to implant properly to be viable, obviously, because it was like so very, very early that it's not even really considered like a full regular miscarriage. But a lot of people will still lump it in there, and I do. I'm like, well, I've had 2 early, I just say really early miscarriages, which they were more like 5-6 weeks, so they were like in that chemical pregnancy zone, and those are usually from like chromosomal things. It can be low progesterone, but usually low progesterone is later on, and we'll talk about that.
Yeah.
Or usually like some immune system stuff. So the first time that I had one was I had a very, very high fever. And right at implantation, I got the flu. And this is like in 2018.
Yeah.
2019. Yeah. And I remembered I'd had a positive and I was like, oh, I was so happy, whatever. And then I had a high fever for like 3 days. And I was like, oh boy, I don't know if this is going to be very good.
Yeah.
And then I don't know if it was that. I just intuitively feel that the inflammation from a fever, which is normal and purposeful, but aligning with a very early implantation trying to take place, and the way that your immune system does have to shift in order to not reject a fetus. I think that was probably the root cause for mine. Also, another common cause of these chemical pregnancies could be if you had like fibroids or scar tissue or something where the baby was trying to implant and it partially did, and it was partially making enough HCG to, trigger a positive test, but not actually grow.
Yeah. Yeah. And I think that it is really hard because it's just everything about pregnancy, everything about the whole journey of creating life. There's so much surrender, but it's so hard. The hardest thing is you just don't know. Like I've had a patient who's had multiple chemical miscarriages, like back to back, not like back to back, like month after month after month, but just pregnant, loss, pregnant, loss, pregnant, loss, all in the early times. And, it's interesting. And this particular person was doing a lot of sauna and like detoxing and other things to try to be healthy. But then, you also want to start looking at the partner. We're not necessarily getting into all the root causes of miscarriage, but just highlighting the point that it can be really hard. It can be really hard in those early weeks, and especially if you've had ones in the past. But
and like the partner, sorry to cut you off.
Yeah, I'm trying to like get out what I'm trying to say is basically like with you, like, oh, I had a fever. Like I do feel like there's like a reason, not always, but something that you can kind of pinpoint to be like, something's not right. And if you can't, start looking outside into other experiences like the partner, because it usually is, like you mentioned, like the chromosomal abnormality or an immune system issue or something where it's incompatible with the continued growth of the baby, which, obviously it's always so sad to have a loss, but there's some reason. Nature's intelligent to be like, maybe this wasn't the best situation at this exact moment to grow a life. And that's never like makes it okay ever. But there's just maybe some wisdom in that. So for anyone who's listening to this, who's experienced that, I don't know if that brings you any peace at all. Yeah,
I do. I feel like it would be harder with a later on miscarriage, of course, to be like, why, what happened, and especially with their repeated, the early ones do have an intuitive feeling and sense to me where it's like, it was never going to, it didn't, the basis of it was not correct. Okay. So I'm going to kind of skip ahead to a different form of bleeding in pregnancy that isn't talked about very often, but it would be around the same time, or it would be around the same kind of root cause where like the beginning formation of the baby was not correct. And it was never going to become an actual human. And that is something called a molar pregnancy. So molar pregnancies are rare, thankfully. Most people have never heard of them.
Mm-hmm.
I would say I don't know anybody who's had one, or even really ever talked about them. But so a molar pregnancy is when there's two different situations. Either for some reason it's all paternal tissue, so it's all dad's tissue, or it can be a partial where it is two sperm fertilize one egg, and
Mm.
it causes a triplody. So it's not necessarily like just one particular chromosome that is there's three of them, like in the case of Down syndrome. It is like there are three cells, and the body does not like that. Now, this is going to be a little bit later on in your pregnancy, like between 8 and 14 weeks, somewhere in there. But it's still that same route where like the very, very beginning was
Yeah.
never going to be right from the beginning. So the bleeding could be sort of like in that brownish light discharge all the way up to like a very heavy flow. But some of the other symptoms that would be going along with it is like it's very rapid growth, because what's growing inside of you is sort of um it could be almost considered like a tumor. And yes, it can, if untreated or undealt with, can transform into like a malignancy, like an actual cancerous tumor. But it's considered sort of like a benign mass, but it grows really fast.
Is
And
this the one
so,
that can have teeth and hair and
oh, that's a teratoma.
oh,
Yes, a
oh,
teratoma. And those would like occur in the ovaries or something. It would be like a mass in the
mhm.
ovary or where the germ cells are.
I see. I
Um,
remember in school,
oh, yeah.
like all the things, and I'm like, wait, which one has the teeth and the hair?
Yeah, not a molar, but yes, a teratoma could. Anyways, and so if you're noticing along with some of those symptoms could be this like rapid uterine growth where you're feeling like, wow, is this maybe twins or something like that, where you're noticing it very fast. And then if we were checking blood HCG, it would be rising like exponentially fast, like way outside of the realm of normal. You would maybe also be experiencing severe nausea because of that HCG rise. And then usually there are like odd bleeding patterns with these sort of grape like clusters they look like cysts. So, like little mini clots that would be coming out. So, but again, this is really rare, thankfully. It does require a DNC. So, that's a dilation and curettage
Mm-hmm.
procedure. And then you also have to avoid pregnancy for 6 to 12 months, and they have to be tracking your HCG to make sure that it's going down, to make sure that they did get all of the tissue, because of this risk of it turning malignant and turning into cancer. So again, like rare, probably never going to need to know about that, but I just wanted to like mention it. It's also sometimes called a hydrative something mole. I can't even say that word, but then also it's sometimes called a gestational trophoblastic disease. Yeah, not very common, but I just had to say it.
Important to know. Yeah.
Yes, important to know.
Helpful.
Okay, and so then coming down the line here, now we're looking at ectopic pregnancy. So most people have thankfully heard of ectopic pregnancy because it is almost always quite the emergency.
Mm-hmm.
So this is like somewhere in that 6 to 10 week realm. It's rarer for you to get like 9 and 10 weeks in with an ectopic, because the growth would be causing you to feel pain.
And for those
Uh,
who don't know, can you just explain briefly what an
yes.
ectopic
Yeah,
is?
yeah. So it's when the okay, so I think that a lot of people think that sperm and egg are meeting inside of your uterus.
Mm-hmm.
But they are not. Sperm and egg are meeting inside of your fallopian tube. So we have our ovaries on the right and the left side, and the fallopian tube is really close to it, but not even touching it, which blows my
Mm-hmm.
mind.
I know. It's like Dr. Seuss. It's like a
Yes.
little
Yes.
filler, like a feeler. It's like a little
Yes, there is this like glove-like apparatus of tissue that is
not
connected to
even
the
moving.
end of the fallopian tube that kind of like has these fingers, and it sort of
Mhm.
does this motion. And because there's all this fluid all around it, it sort of is creating this little bit of a current. And so the egg comes out of the ovary and it's sort of drawn into the fallopian tube. And that is where the sperm is usually meeting it. And so the sperm, when you have sex or you have IUI or something like that, is going all the way up into the uterus, and then it's traveling all the way up to the tubes. Like it has a long ways to go.
Yeah.
And
Also
especially
incredible.
yeah, exactly. It is incredible, especially for such a small cell.
Yeah.
Okay. And so if it decides that's normal, they meet there, they fertilize there. Then they sort of bounce for several days down the tube towards the uterus, and that ball of cells is dividing and splitting and doing things so that by the time it comes down into the uterus, it's ready to implant.
Mm-hmm.
And then it can look for its little special spot in the uterus. It has very like particular um, conditions that need to be
Mm-hmm.
met. And, these like amazing chemo sensors that sort of tell it where to go. That'll be like a good spot versus a bad spot. Anyways, but if for some reason all of that process happens in the tube still, and the embryo decides to implant in the tube or outside of the uterus, anywhere outside of the uterus, it could actually go into that interstitial space, like around the ovary, sort of in your abdomen.
Yeah.
But the tube is definitely the most common spot. And then it grows there. And that is almost always, and I'm not going to say always, because there has been like one case or like maybe two where an ectopic pregnancy went to term. But it's like a extreme, detriment possibility to mom because things can rupture and bleed, and, she could internally bleed. But anyways, it's something that needs to be dealt with and is not going to be compatible with life in almost all other cases. So if we catch it early, which you would catch it in the situation where you're having severe one-sided pain, because it's going to be in either your right or your left side, not both. So with early pregnancy, it's normal to have some cramping. And this
Yeah.
can also really trip people out because they're like, I'm cramping. Like, what does that mean? Like, I felt this kind of like low period ache feeling. And it's hard to say like, oh yeah, it's totally fine. It's hard to say that. We can't actually really even say that. Some people, that is going to be totally normal. Some people, it's going to be the start of a miscarriage. So
Yeah.
unfortunately, when we feel things, we just have to try to convince ourselves that it's normal until we know that there's more signs that show that it's not normal.
Yeah.
Okay, so, but with an ectopic pregnancy, you're going to feel right or left pain that is usually quite extreme, like to the point where we are like dizzy, fainting, nauseous, vomiting, like it's extreme. Sometimes also you can have shoulder pain because of the referred nervous. I barely slept last night, so I'm sorry.
I can't believe how great you're doing. I don't sleep at like at least 9 hours. I'm like dead.
9? Oh my God.
I mean, not straight, but
That
in
would be
total.
wonderful. But yeah, you can have like a shoulder pain because of the nervous system sort of referral pain. And so you would go to like the ER. This is an absolutely emergent situation. Sometimes they're able to give you a medication that dissolves it, where it's going to just make the cells dissolve and go away, and then you could just pass it and you can keep your tube. But oftentimes it does result in a surgery where we are removing the whole fallopian tube. So now we only will have one side in which we can have a successful conception. And it is what it is. It's a life-saving surgery, because if it ruptures, if the fetus inside is growing and growing and growing and growing, and that tube can only stretch so far, and then it will rupture, and then there can be internal bleeding that is really life-threatening to mom, and obviously the baby is not going to be able to make it regardless.
Yeah.
So that's an immediate medical care seeking situation for an ectopic. And again, usually I would say the most common is like 6-7 weeks for those, because you're going to be feeling the baby is growing so fast, you'll be feeling it. To get to 10 weeks with an ectopic would be on the like more rare side.
Yeah. And now, would people have bleeding with that, or it's more just the pain that you would know?
Okay. Yes. Sorry. Good. Glad that you said that. Yes. You would also usually have some bleeding. You may not, and that can be okay too. But if you are having some bleeding and the pain, that would be sort of like the more common constellation of symptoms where a provider is going to go, oh, shoot, we really need to rule out that this is ectopic.
Mm-hmm.
And sometimes, unfortunately, if this is happening very early on, like 5-6 weeks, and a woman is really sensitive and able to feel, but they go in and they do a transvaginal ultrasound and they cannot really tell what's happening, but maybe they see the tiniest little blip on an ultrasound of something growing in the tube. The protocols in most cases are going to be to treat it as if. Yeah. So they are not going to want to wait and see. But if they scan the whole uterus, they don't see a baby in there, but you have HCG that's rising. So maybe they're doing some blood tests a couple of days apart. Your HCG is going. They look in the uterus. There's no baby. They look in the tube. Maybe there's a suspect thing that they're like, what is that? I don't know. They're going to treat it like it's an ectopic because of just the risk is too great.
Yeah.
Yeah. Okay. So I know some of these are downers. I'm sorry.
It's a fun podcast.
Yeah. Really, really fun. It's just good to know, though. Like, I think all of this stuff is empowering, and we are women and we need to know.
Yeah, we need to know this.
The possibilities of what can happen in our bodies, right? So, okay. So now let's talk about threatened miscarriage and like a low progesterone type miscarriage. And then we're going to talk more about like an actual miscarriage in a minute too. But so in the case of a sort of threatened miscarriage, maybe the baby is growing fine. Everything chromosomally about them is fine. Their implantation is fine. Their placenta is fine. But for some reason, mom, the egg that the or the follicle that the egg came out of was sort of on a maybe a suboptimal health level, wasn't making very good progesterone, and we're like barely skating by that the body even knows that we're pregnant. Okay,
Mhm.
because what can happen is that if we just don't simply don't make enough progesterone, there may be a baby there, but the body doesn't know, and it just flushes it out in like sort of a period. It may be a little bit late. Maybe you hadn't even tested yet. You didn't know. Like there is a lot of pregnancies that happen where people don't even know that it's happening. But so if you are wanting this baby, this was an intentional situation. This is where, I know you talk about it. We talk about it a
Mhm.
lot. And sometimes the conventional world is hesitant to supplement with progesterone or test it because they're like, well, we don't really know like what the level would be. It's like, well, we do know some
Yeah.
things. And progesterone is a very benign supplement to take that could be saving your baby's life. So it's
Yeah.
like,
Yeah. I mean,
why?
I'll just tell a story. I'm sure she'll be
Yes.
okay. I'm not going to say her name, but like a classic person who would come to see me is, I'll just tell a couple. One patient in particular, she had had a miscarriage around 7 to 9 weeks, right? So the bleeding started, and then it did end up resulting in a miscarriage. And no one had done anything at that point, like most women, no testing, nothing. When she came to see me, we did test her progesterone mid luteal phase. So not during a pregnancy, just at a different time. And it was like 6, 7, I think, if I can remember, 8, around there. Not enough. You need at least 10. Better would be 15 or higher in a mid luteal phase during your cycle. So a week after ovulation. So we worked on all of the things, all the lifestyle stuff and the things that really impact progesterone. And for some people, it's enough to raise it naturally. But for her, she was just nervous. We weren't sure. And her progesterone maybe went up a little bit, but it still wasn't as great as we wanted. So I supplemented her with progesterone in the second half of her cycle. And she was able to then conceive and carry that baby to term. Everyone could say, like, well, maybe the first miscarriage was just a fluke and she would have been able to carry the second baby. Maybe, but I did her testing and I know that her progesterone wasn't high enough. So knowing what we know, most likely not. It probably would have resulted in another miscarriage. But that is a different example. Another patient, I don't even know if she had a history of miscarriage. She might have, but or no, I think this was maybe the same patient. She wasn't on progesterone. Her things had healed after the first baby, and she got pregnant again and like didn't need that help. She didn't need the progesterone help. But then I remember she messaged me. She was 7 weeks and had been on a flight. And so like flying is stressful, right? You're stressed, your immune system, there's a lot of factors that can affect your progesterone. And she had started spotting. And
Mm.
because we knew her history, it's like, uh-oh, most likely this is a low progesterone thing. You're right in that window of 7 to 9 weeks. You have a history of this. You're not on supplemental progesterone right now. So we tested. It wasn't quite adequate. And we just, actually, I think I started her on progesterone right away without testing because I didn't want to risk, we
Mhm.
didn't want to
Mhm.
risk losing the baby just in case. It's not going to hurt, right, to be on it. And the bleeding stopped after being on progesterone and she went on and had that baby. And so it's just like an example of sometimes people don't know, so that it ends in a full miscarriage. And sometimes you can prevent it by catching it in those early weeks. And this is where it's tricky because I've also had patients where they've started bleeding and then they're like, oh, maybe I just need progesterone. We start them on progesterone and it doesn't. That wasn't the issue. It was most likely a chromosomal thing and it resulted in a miscarriage anyways.
And that's
So
a
it's
good
not,
thing, though, I think about
yes,
it, because
totally.
you don't want people thinking, oh my gosh, wait, are you keeping a baby in that was
Right.
not meant to be in?
No, if there's a chromosomal issue, if there's some anatomical issue, some physiological issue with the embryo, having adequate progesterone is not going to make that baby grow because progesterone should just be adequate in all of us, right? There should be a high enough amount, even in women who have miscarriages from a chromosomal perspective, have plenty of progesterone. So that's a question I get a lot of, well, if I take progesterone, is it going to make a baby stay that shouldn't? No, not if there's an other issue with the baby, but it can make a baby stay who maybe would have been lost otherwise if that is the only thing. So I'm just saying I've had both experiences. And
Mhm.
so throwing that out there as an example, that even though, let's say you do start bleeding, if it is progesterone and nothing else, you could potentially still save the pregnancy. Let's take a quick break to hear a word from our sponsors. Did you know that 97% of women in the US take a prenatal supplement, yet 95% plus are still deficient in key nutrients? My favorite prenatal is from a company called Needed because they dose nutrients at levels to not just meet the bare minimum as most prenatals do. They actually use form of nutrients and dosages that allow mama and baby to thrive. Needed actually approached me years ago and asked me if I could help them design the perfect prenatal because they knew that the current prenatals available were not actually helping women. We spent over 3 years diving into the research and understanding what practitioners are seeing and what women actually need at this important season before we formulated this amazingly supportive option. It's no wonder over 4,000 practitioners now recommend Needed, something I am very proud of. If you have followed me for a while, you know that prenatals and optimizing nutrients starts long before pregnancy, so no matter where you are along your fertility or motherhood journey, Needed is the brand I recommend. Head to thisisneeded.com and use code HEALTHYMOTHER to save 20% on your first order. Again, visit thisisneeded.com and use code HEALTHYMOTHER to save 20%. Okay, back to the show.
Yeah, and just to clarify too about like what we mean when we say chromosomal things is not like, Down syndrome. What we're talking about is like when the initial cells are splitting, if things are so disorganized in a way that's not compatible with life. That's what we mean.
Yes.
Like it would never, ever, ever grow to a human. It's not like, oh, we don't want to keep Down syndrome babies. That's not what we're saying.
Yeah. Right. There are certain chromosomal abnormalities that are compatible with life. Things like Down syndrome.
Some of the other trisomies, yeah.
Yeah, like some of the trisomies, but there are some chromosomal abnormalities that are not compatible with life. It doesn't matter how badly you want them, it's just like they literally are not going to, it's not compatible with life. So that's what we're talking about. And that's what typically results in a miscarriage.
So then how do you typically dose it for an average woman who, let's just saying in the most common case, was working with you or has a history or knows that they probably don't have very good progesterone. And so then they get pregnant, they test themselves. They're like, this is not that great. I should probably get on something. What do you normally do? Like there's oral, there's suppository. What do you typically like?
Yeah, I mean, I've done oral and suppository before. The research is definitely stronger in the suppository world. And so let's say someone tests their progesterone and it's 8-9, 7-8-9, something like that, like not adequate enough. If we're actively trying to get pregnant, they're not currently pregnant. We're not trying to save a baby, and they're just currently trying to get pregnant. And we're doing all the other stuff, right? But we're still not getting high enough progesterone. I'm probably going to supplement with 200 milligrams, usually vaginally, like a suppository. If they're like 10, 11, 12, it's like not above 15, which is where I love it, but it's not terrible. I might do 100 and then retest and just kind of see how the body's like responding to that. But I'm not afraid to do like, 200, even 200 twice a day, even up to 400, even 400 twice a day. It just depends. I typically don't feel like I need to go up that high when people are just trying to conceive naturally. In the IVF space, people are on a ton of progesterone, but in the IVF world, typically cycles are being done in like a fake way, meaning that your body isn't making any of its own progesterone. Yeah. And in that case, dosing much higher. And if you're working with a fertility doctor who's mostly used to that world, they might be dosing you higher. But I'm just a big fan of giving the progesterone and then retesting to see what's going on with your body and if we need more. So 200 milligrams, maybe for some, 200 milligrams twice a day, just depends. It will make you tired. So typically if we can get away with just once a day, 200 milligram vaginal suppository at night, I'm typically not going to necessarily do a lot in the morning unless we need that, just because it can make people tired. If they're pregnant and we're trying to save a baby, I don't care if you're tired. You're going to be tired anyways. So it's like, we'll do it twice a day. We're going to do anything we can to save the baby if that's the situation. So that's typically what I would be doing for someone who's actively trying to conceive and only started 4-ish days after ovulation. If you start progesterone before ovulation, you'll obviously prevent ovulation. We don't want that. Progesterone should only be high after you ovulate. So that's what we do. We mimic that, giving them the progesterone, for 3 to 5 days, typically 4 days after ovulation. And then you take it until either you get your period or you're pregnant, right? And so
but you don't stop when you're pregnant.
correct. If you are pregnant, you do not stop it during the first trimester. If you are not pregnant and you have your period, you can take a pregnancy test just to confirm, because we're talking about bleeding in pregnancy. You might be like, oh, I'm not pregnant, I'm bleeding. If you're in that season, I would probably still take a pregnancy test just to make sure it's a for sure negative. Then you can stop the progesterone, have your period, and then you wouldn't be on it that whole next to your first cycle until you ovulate again. And that is what is progesterone is so important, because it not only helps the embryo implant, it also keeps it in the uterine lining. So it helps with implantation and it helps with keeping baby, like holding baby in. And then, if you are pregnant, you would stay on the progesterone. I'm a big fan, again, of testing. You can even test on your own through labs like Ulta Labs. You can do progesterone tests, but you would want to stay on that progesterone, making sure you have enough. You might have to up it depending on your situation, and you would want to stay on it until at least 10 weeks. I'm more conservative, and I typically go till 12. But your conventional doc would tell you about 10. You can just stop it. I don't know. I just go a little bit farther. I just feel like it's not hurting anything, and I slowly wean people off. So not like crazy slow, but if they're on 400 milligrams twice a day, I drop to 200 twice a day, and then 200. And then, I would probably stop after that.
And how come you choose suppository versus oral?
I've done both, and the studies are just mostly in vaginal. People think that it's because I personally don't necessarily agree that they're like, well, it's local, and so you're putting it in the vaginal canal, and so it's going to affect that. But hormones are systemic, so you could take it orally as well. The oral is going to definitely affect you more sleep-wise. So, we prescribe oral progesterone all the time, especially for women in peri and postmenopause when they're actually having sleep problems, because we want that effect. So I wouldn't be opposed to oral. It's going to bypass, it's going to go through your liver and the biotransformation of your body. And so it affects things a little bit differently. And because the studies are mostly done on vaginal, any conventional doc is going to feel more comfortable if you're on vaginal or coming in on vaginal, because there's just more studies done on that. And that's just how they orient themselves. But I've done both with people, and it can be kind of personal preference. But
you could also do, I think I've heard you in the past doing suppository in the morning and oral at night.
Mm-hmm.
A bit of a mix. Just because suppository twice a day is
yeah. Well, and the other tricky thing with suppository is not that this is the main concern, but anything suppository is going to be in an oil base. And depending on what that oil base is and what is in it, it can change your vaginal microbiome.
Oh,
so it's I don't know. I mean, we do the best we can. I mean, my doctor for my IVF, he actually gave me gel caps of progesterone. So it wasn't even a classic suppository. It was a gel cap. And then I would puncture it with a needle and then put that up there. But it was in a peanut oil, it's not great. A lot of the things. So there's pros and cons to both, but it just depends on what is important to a person or what they can get access to. And again, it's let's say you do oral, that's why I want to test. Let's say you test your progesterone and it's 8-9, and then you take oral progesterone.
Wait, just really, really quick for the listeners. You're testing your progesterone at 8-9 would be that 1 week post ovulation, not when you're pregnant.
So mid-luteal phase progesterone, a week after ovulation. Let's say you go in and do a blood test, and it's 8-9. It's not ideal. We want it above 15. Ideally, above 10 is the minimum. And let's say I give you oral progesterone, and you're on, 100 milligrams of oral progesterone, let's say. And then 2 days later, I have you retest that progesterone. If it hasn't really budged much, if it hasn't gone up much to at least, 12, 13, then I'm thinking, okay, I don't know if oral is going to be the best for you. For some reason, your body is not responding very well to that. So maybe we try vaginal. So it kind of depends on the person too, if that dose is high enough or if the form is best. This is why they call it practicing medicine.
I was just going to say.
It's you're literally, everyone's an experiment. We glean what we can from all of the advice from everyone else and experience that we have. But at the end of the day, the person in front of you is an N of one, and you have to just kind of experiment and see what works best for them. And then, like I said, I've had patients where we thought that it was progesterone. They had low progesterone. We gave the progesterone, gets pregnant, keeps losing babies.
Yeah.
And so that's something else that's going on, investigation. And in this particular case, it was weird because she had normal, healthy children at other times. So it's not like she had some crazy, genetic clotting disorder that like would not let, her carry a baby. It was just, and so that's where I'm looking at partner. And that's where, so we have to go into all of these other places because that's weird. It's a weird thing to me when a woman has had a natural, normal pregnancy and then has like miscarriage. It's like, what is going on? Like,
Yes.
sometimes people have genetic stuff. And I know this episode isn't about miscarriages, but
I am going to put in the show notes, we have an episode about miscarriages and we have an episode about progesterone. So I'm going to do that because I think that this will be really interesting for people who are in this world. One last question is because I'm sure people are listening to this who are trying to conceive and maybe it's just not happening yet. And they're thinking themselves like, oh, I definitely must test my progesterone. And obviously there's no harm in that. But can you describe sort of like your general situation of a woman where you're like, you should go and test this and just see what's happening?
Yeah, like if to think that they might have a progesterone issue.
Yes.
Yeah. So if you really struggle with PMS, if you really struggle in the symptoms before you get your period, the week before you get your period, you're irritable, you feel like you can't handle anything. You're just like overwhelmed by everything. You're on edge, you're anxious. That's how I feel right now. Maybe I don't have any progesterone. Probably not because I'm not ovulating. Because I'm postpartum. And
I just ovulated, but I feel the drop off bad.
Yeah. So progesterone is your chill hormone. It's like chill, cozy, like what it like helps you deal. Progesterone helps you deal with your life. It helps you, survive. And if you don't have enough, you feel kind of crazy, especially in that week before ovulation.
No, before your period.
Right before your period. Yes, I'm so sorry. It also probably helps with your brain. I don't have any. Yeah, so the week before your period, a week after ovulation, so in those days before your period, if you feel any of that, if you have spotting before your period. So this is what's tricky when we're talking about bleeding in pregnancy, because if you are a person who is actively trying to conceive, it can get all confusing because let's say you do have some spotting and it's before your period and you're like, oh my God, it's implantation bleeding, And then you take a pregnancy test and it's negative, 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 negative. What is going on? It could be that you actually have low progesterone and that causes, think of progesterone as the hormone that is like a dam that holds the uterine lining up in your uterus, okay? So estrogen builds the tissue. So you've got lots of estrogen that builds the tissue. If you don't have a lot of estrogen, you don't have a lot of tissue, meaning you have late periods. But you're building all throughout your cycle during ovulation. And then progesterone comes around and is like, let's keep it in place. Let's hold this dam up because we're waiting for this baby to come, right? If you don't have enough progesterone, it can't hold that dam. And so it starts to break through. And when that breakthrough happens is when you get spotting and spotting before your period. So you might think you're having early bleeding. You might think you're having chemical miscarriages, but the difference is you're having no positive pregnancy tests. In that situation, I would absolutely get your progesterone checked mid-luteal phase. And obviously, if you're not currently trying to conceive, then that's a huge red flag because there should be no other reason why you'd have spotting before your period other than having low progesterone. So yeah, any of those symptoms, even sleep issues, if you feel more irritable, like you can't sleep before your period, if you're having insomnia, all of those kind of things, anything that makes you feel off, I would definitely check your progesterone. It's so much more common than it probably ever used to be because the things that kill it the most are stress and inflammation and nutrient deficiencies. Okay, there's 3.
Okay. Great.
What a lot of people have these days. So
yes. Okay, cool. Thank you for that. I love that analogy about the dam. That is exactly what it is. And we have to think too, every month our body is like hoping to get pregnant.
Yeah.
Like every month. It's like, oh, right, is it this time? Is it this time? And it just sort of continues to give. One of our colleagues in school, Ariana Pulakos, now Ariana Zastro, said to me one time, and I wrote it down because I thought it was so beautiful at the time. She was like, the ovaries, they just give every month without knowing what's going to happen. They just like make this egg and they release it into the world and they're like, go on. I hope you make something.
Be a baby. Oh my God, that's so crazy.
And it's so sweet. It's like just every month, like it's just a sacrifice that you're.
Oh my God, that's such like a metaphor for like the feminine though.
I know, isn't it poetic? It's so
Like,
pretty. I'm like,
and
oh,
like mothering and feminine energy, which is just like giving and giving and giving, and
yeah. That's
why women are so depleted.
I know. And then why women get, there's like that energetic piece of cancers.
Yeah.
Because we have to be taken care of too. We cannot just constantly be taking care of other people, and we will just become empty sacks. Like I always, I would make this self-deprecating joke with when I was on the other end of my hard postpartum with my first, that I was like the mother octopus. There's like this one species of octopus. I don't know, maybe there's a lot of them, but at least there's one species of octopus that like lays over her den of eggs and dies on top of them. And when they hatch, they eat her body, and that's their first meal. And I was like, this is how I feel. Like, I feel as though I have given everything to the point where like I'm dead.
Yeah.
But we can't do that. Like, we have to put our own mask on first, and it is hard. But then at the same time, it's instinctual and it's deep, and we do sort of like have to also sacrifice a lot for our children, but we can do it in a way where we are still self-preserving, and it's a balance, and you have to learn how to do it, and it's hard, and putting up boundaries with your children is hard, but I am getting a lot better about it now, where I'm just like, I'm not doing that. I know you want me to, and I hear you. Sorry.
Yeah. So for anyone who is trying actively, who doesn't have kids, there's such a wisdom to the female body, because I feel like progesterone is so much of that nurturing hormone. And when we don't have enough because we're not giving ourselves enough, it won't be high enough for us to have a baby, So there's an intelligence there, and something I grapple with all the time when I bring in the support of progesterone, which is why I'm not really quick to just do that without all of the other lifestyle factors and the self-care factors and the stress reduction factors, because there's an intelligence there where if like you're not giving to yourself enough, if you're not nourishing yourself enough, if you're not resting enough, if you're not, creating that space for yourself enough, then progesterone is not going to be enough to say you are now ready to give to another. Right. So
wow.
I know.
Wow. That is really, that's huge, and I, similar, but not quite exactly the same, is that people often ask me, like, how do I get my period back when I'm postpartum and I'm breastfeeding still, because we want to have another baby. And I always explain, I'm like, you don't have a period back because you're still nursing a baby, and your body is not feeling fertile yet. Again, it doesn't want to do that. And I understand that sometimes people are on a clock. So, they're getting into their early 40s and they're like, no, I need to do this right now. So, you have to do what you're going to have to do. But I think in the vast majority, we sort of need to look at that and go, okay, what is happening here? I probably, is my body replete enough? Because some people will be able to nurse and have a cycle and also get pregnant and then tandem nurse. I mean, and those people are probably eating so much and are very low. These are the mother goose types. This is the constitutional. Yes, this is the kapha mom, the mother goose who is like just absolute chill, has probably
not stressed.
Yeah,
because she's got plenty of progesterone.
Yeah, she's got tons of progesterone. She can just keep popping out babies, and it's like no big deal for her. And that is not the way I am. I have never.
We're stressed.
I know. I have never tested my progesterone. I've never tested any of my hormones.
That is so crazy. I want to so badly. We should, and I should just go over them with you live on a podcast. And I think that would be really fun.
Let's do it. I would love it, because I'm curious. Like, I don't. Anyway, all right. Okay. I want to move on to the other things, but we should do that. Let's make a note. I think it would be fun for listeners too, but it would also be fun for me to get a free assessment of your brain.
Yeah, of course.
Okay. So there are a couple other causes of first trimester bleeding. I'm going to go through two. They're on the like quicker end. Well, then we're going to talk about miscarriage, like full on miscarriage, which I know we just talked about a lot. Actually, let's just dive, kind of like keep going through that. So these early threatened miscarriages are from a low progesterone standpoint. We've covered that, right? So like that can be one of the causes. We can also have miscarriage though for a number of other reasons. Maybe it is one of those chromosomal abnormalities incompatible with life, like we talked about. Maybe it's something called a missed miscarriage, where it was something like a blighted ovum, which just basically means that like a fetus never develops. Like there's the sac, but there's no baby inside of the sac. And so something along the lines of those, literally every single baby, you guys, is a miracle. Like,
I know.
Every
I
baby
know.
is a miracle.
Every single one.
It's
Every single one.
crazy. It's crazy. If you want to know what happens, go to YouTube and just type it in and watch. Maybe it'll feel too sciencey for you, but the point is that our cells do this division in this perfect way, and everything happens usually perfectly 75% of the time. So now, just so that everybody knows, 25% ish, 1/4 of pregnancies ish end in miscarriage.
Mm-hmm.
And so most of the time, though, 75% of the time, everything is going to go totally swimmingly well, which is absolutely mind-blowingly amazing.
Yeah.
So in the event, though, that something happened, maybe your body doesn't recognize it right away. So this is really unfortunate and really sad, in my opinion, because people will think they're pregnant and they are not. They are not growing a baby anymore, or their baby has halted growth. Maybe there was a baby and then it stopped at 6 weeks, or there was a baby that never got a heartbeat or whatever. And they're now at like 10 weeks and they're getting an ultrasound or something for the first time, and the baby is actually measuring like 7 weeks. So that's called a missed miscarriage. And it's when your body just didn't quite, it missed it. It just didn't, like, you just haven't bled yet. You haven't removed the baby from your body yet. But so there's a lot to do, a lot of different kind of nuances to miscarriage. Again, we're going to put that episode in the show notes.
Yeah.
This is most common between 6 and 10 weeks. And there is a tenet about if we see a heartbeat, the chances of miscarriage drop a lot. So if we hear or see a heartbeat on any kind of ultrasound or Doppler situation, then the chances of that baby going to like birth are a lot higher
Mm-hmm.
than when we haven't seen that, or it's just not been that time period yet. And so a lot of times this is when people do want to get an early first trimester ultrasound. And I am of the opinion, speaking of our stress conversation we just had, if you are very anxious, which I have done this with 3 of my pregnancies, not the 4th one, I don't know why, I just didn't feel that stress. But I like tried really hard not to get first trimester pregnancy or first trimester ultrasounds. And I try to just like trust and just be one with nature. But I couldn't. And I was making myself miserable, wondering, is this baby even growing inside of me? Like, what is happening? I need to see a heartbeat. I need to know if this is going to be a baby or not. So do it. Then go and get an early ultrasound. Like, it's not that big of a deal. You can do it quickly. It can be fast. You can use it also for due date purposes, which I'll link the other episode that we did recently that was called, Okay, You're Pregnant Now What? And we talk at length about the importance of due dates. So I'll link that. But there's a time and a place for this sort of information so that we can see it.
Yeah.
And so just some of the characteristics of miscarriage too. So like it can start out as light bleeding, but it will eventually get to heavy bleeding.
Mm-hmm.
Sometimes there could be clots, there could be tissue, depending on how pregnant you were. You may see the entire whole sac and placenta and baby inside of like a little water balloon looking thing. And for some that can be healing and closure. For some that can be really traumatic. So to know that that is a thing is important. Sometimes it's very crampy. Sometimes it can be not, but most people report that it's extremely crampy. Now, if your body is just, the miscarriage has continued and your body is not like getting the signs and signals that this baby hasn't grown, this is where then we can go and seek, depending on the size of the baby, either sometimes like a medication form of, okay, so these are like the abortion medications and abortion treatments. But this is a baby this is not an abortion. I mean, actually, medically, miscarriage is considered an abortion, but
Mm-hmm.
that is obviously not the same kind of thing. But either way,
It's a spontaneous abortion,
yes.
meaning the body did it.
Yeah, the body did it. It's, yeah. But you would be taking that same drug if it's a very, very early on one that would cause contractions, open up the cervix, and you would expel the pregnancy that way. Or we can do something like a DNC, which is what we talked about earlier, which is the procedure where they go and they remove the tissue. They're scraping the inside of the uterus. And sometimes your provider, if you want to wait and see if your body will do it on its own, you can wait a certain number of weeks and things. We do just need to have it in our cognizant back of our mind that that tissue now is not like living and thriving, and it has a chance for getting infected and things. We need it to get out at some point. You cannot just hang on to this material for a long time. I do have a cool story though of a friend that I know who had a miscarriage of weeks and weeks, and she was really waiting and waiting and waiting. And then finally was like in the bathtub one night and was like, had a moment talking to her baby and was just like, you need to go. Like, this is time, you need to go. And then either started bleeding like right then or the next day or something. Like, there is a mind body connection that we can have to this situation. But so that would be like the the treatment or sort of the sequelae on the other side of miscarriage. Oftentimes the body will just do it on its own, but if we need some help, we have that option too.
Yeah. And we can do a whole episode on that. I actually, eventually one of my friends who's had a later term miscarriage will probably come on the podcast and talk about that too, and just navigating those options and the choices. And it's a heavy time for sure. And making those decisions can be hard, but it's just another thing to know about with bleeding. And then what comes after that, it's like a whole thing. So we'll do another episode on that, hearing from someone who's been through that experience.
Oh, that's sad. Yeah. Yeah. We all need to know that it's possible. I also feel like it helps us hold reverence for every baby. Like we were just saying, like the fact that anybody has an actual child in their arms is like insane.
Such a blessing.
It's insane. Okay. So some of the other causes would be something like a cervical irritation. So this could happen because you had penetrative sex and the cervix gets touched, and it is full of blood vessels, and it's called friable, friable, and it just means that like throughout your entire pregnancy, a lot of your tissues are friable. Your gums are friable, the inside of your nose, your nasal passageways are friable, so they bleed easier. People will have nosebleeds, or their gums will bleed when they brush their teeth or they floss or something like that. It's just a thing of pregnancy. So with exercise or sex, oftentimes we can have a little bit of spotting. Usually it's just like a pink or brown blood. It's not bright red. Yep. Sometimes though we can have bright red if we had something like a pelvic exam for some reason, which normally we don't do during pregnancy, but if we had to, or if like you had a polyp, if you had a cervical polyp, those can bleed bright red blood. And so this is why we get our pap smears, one of the reasons why. But to figure out like, is there anything like that growing on my cervix that I would need to know about? Yeah. So in this situation, this is like normal. We don't do anything about it. It could be maybe even just like, something that you experience just for like a certain time of your pregnancy and not throughout the entire time. Sometimes there's a little bit of increased vaginal discharge with it, sometimes not. Again, this is just like one of those benign reasons that you should know about so that you can say, oh, did I have sex last night? Okay. Am I waking up in the morning and going pee and there's like a little bit of blood on or a pink something? It's probably not a miscarriage. It's probably from my cervix and it's not going to continue. It'll stop.
Yeah.
Okay. And then infections. So we can have vaginal infections or cervical infections that can cause some bleeding, some sort of a light spotting in pregnancy that would not be because of the baby something's wrong with the baby. Although untreated STDs or infections can affect babies. So we do need to, but it's not coming from the uterus. It's usually coming from like the lower anatomy there of the cervix or the actual vaginal canal itself. So usually you would also have the symptoms of something like unusual increased discharge that maybe smells or itches or burns or is a different color, like it's gray or it's green or it's yellow, or like a yeast infection even sometimes can cause some bleeding because it damages the mucosal lining, or if you're itching and then you're breaking open tissue in that kind of a way. So if there's any kind of chance or worry that you're having an STI during your pregnancy, we definitely need to be seen and treating because they can affect babies negatively. Yeah. And also at the time of birth, of course, we don't want to be having any kind of an active infection in the vaginal canal, ideally. Okay. So do you have anything to say about those?
Just, what was I going to say? I was thinking of another patient, not a patient of mine, a patient of a friend's who, they had an infection and it was like they were getting close to giving birth. And it's like, you need to probably treat that. And it sucks sometimes. Like we talk a lot, you and I are naturopathic doctors. We love doing everything, as natural as possible, root cause stuff. And just like everything we've interwoven throughout this episode and others, there's a time and a place for treatment. There's a time and a place for diagnostic. And so are there other root causes? Because I wanted to wrap up with a question.
Subchorionic hemorrhage, yeah.
Oh, okay. Because I was basically going to say for the person who they're pregnant and they're now experiencing bleeding, like what is the path to go down, right? Obviously they should go to their doctor, but like what kind of things to expect? But go through the subchorionic.
Okay.
First.
Yeah. So this is a big one. Not necessarily that it's super common, but it's more common than you think. And it's usually something that nobody's ever heard of. And it's usually something that everyone thinks they're having a miscarriage because the blood is a lot. Yeah. It can range from like a small spotting, but I would say in most cases, it's like blood. Like it is a lot of blood and you're going, there's no way that I'm still pregnant. Like this is a miscarriage. But it's not. So it can be bright red or brown, and it can literally dump out of you. I actually have a subchorionic hemorrhage, so SH highlight bubble on my Instagram account, because one day we were getting into conversation about this because somebody wrote me that they were having one, and I sort of like crowdsourced with all of you followers, and people wrote in their stories. I screenshotted them, shared them in my stories, and I put it in highlight so that you can read different stories about the way that it went for women. Some of the cases are like blood is like splattering onto the floor. They think they're like hemorrhaging. They go to the ER. Like it's a whole thing, and baby's completely fine. It's because, okay, what a subchorionic hemorrhage is a pooling of blood between the placenta and the wall of the uterine lining. Usually they'll talk about it in terms of a percentage. They'll also sometimes call it like the lake. The blood lake.
Blood lake. Yeah. Like in one of our fantasy books.
Yes, exactly. It does. Or like a pool. And they'll say, oh, it's like at, it's a 30% subchorionic hemorrhage or whatever, meaning that like 30% of the space underneath the placenta has essentially a clot underneath it, or a blood, which will just slowly over time reabsorb. And most of the time subchorionic hemorrhages resolve spontaneously and everything is totally fine. But sometimes you do have to be monitored more frequently, or you have to do things like go on pelvic bed rest, which would mean like no exercise, no penetrative sex, because they don't want to jostle or bring attention or more blood flow to that area that could potentially make it where the entire placental, it would almost be like a placental abruption if it completely came away, which it can result in a miscarriage, but it's just not as common as what you'd think. It feels very crazy and scary, and the amount that you see, you're just like, holy crap. And you can have some cramping, but usually people have no pain, which is another sort of characteristic about it. But so you would, if that is ever happening, you would go in and go get an ultrasound like right away, maybe at the ER if it's happening over a weekend. And this can happen anytime in the first trimester. So 6 to 12, 13 weeks, anywhere in there. I mean, the first trimester is 4 to 13 weeks, but just to say that, like, you'd have to be at least a little bit pregnant where there is like this placenta on the wall. But so if that's happening to you, one thing to know is that there isn't really good clinical trials about this yet, but there is a lot of sort of anecdotal and clinical use where people are having success with something called alpha lipoic acid, ALA. ALA is basically just a nutrient, you could think about it, that reduces stress and inflammation. Oxidative stress is what I mean, not like your brain, mental stress. It can help your blood vessel function, which is important when we're trying to resorb a large amount of blood, and also so that we're getting enough adequate blood flow to the baby so that baby can continue to grow. It also can stabilize the blood vessels. So the dose is usually, this is not me giving medical advice, this is me just like giving information to talk with your provider about, to say, hey, do you think this would be a good idea for me to try, since the potential side effects are very low. But again, we don't really know if it's like that effective for it even to be worth it. This is where we need the trials. But it's like a 200 to 300 milligram twice a day dosing usually. It's one of those things where when we have a situation that may end in a miscarriage because it's maybe like a really large hemorrhage, it's sort of like, I mean, let's throw everything at it that we can. Like, why not?
That's great. And I think that's really important to note about this because, like you said, a lot of women don't go to medical school. Obviously, even if you did, this is not very well known. Obviously, we have doctors and providers for a reason, but these things are happening often in our own homes, in our own rooms. We're not like in a medical setting when we start bleeding in pregnancy. And so just knowing this as women is so important, because you might think, maybe you're having a subchorionic hematoma and you might just think, oh, I had a miscarriage, my baby's gone, when you're like literally are still pregnant.
Yeah.
Or vice versa. You might think, oh, that was probably just, I don't know why you'd ever think this. I guess if you listen to this podcast, that was probably just a subchorionic hematoma and my baby's fine. And it's like, this is where we need to go and know that our options are, know what's going on, and utilize the tools that are, at our disposal. But just being more empowered. Anytime you have more knowledge and education, you can go into the medical setting more empowered to know, kind of what to expect, how these tools can be used and helpful, because it is so mysterious at this time. And that's kind of what I wanted to wrap up with was, we've highlighted different times in the first trimester, or like you mentioned, I don't think you've mentioned yet, just unexplained. Like we don't know. for like the bleeding?
Yeah. So the unexplained ones would be just things like, sometimes in some women, they're going to have with their increased blood flow, or the hormonal shifts, which has not like on a progesterone side of things, but they're just going to bleed easier. And so I do know women who've bled the entire pregnancy, like off and on, not every day, but it's like, why? What's going on? And they never get an explanation, and everything is fine with the baby, but they just, don't know. Or if you have some kind of a known clotting disorder where your blood cannot clot very well, so you have like a thrombophilia or something, that's not really considered unexplained then, because we know what's happening. But there is a portion of people who will never get an answer, but they can be monitored as they wish to say, well, the baby is okay. Like, this is not the baby. Yeah.
Yeah. No, that's good. So yeah, as a wrap up, I would say if you are a person who is pregnant and you're experiencing spotting, bleeding, listening to this episode, going through the things that we talked about as to the quality, the intensity, the timing, and then, going into your provider, if it's not an OB-GYN, your primary, going into the urgent care, depending on what you're experiencing, because we can pretty easily rule out some of these things quite, early on. And then, get to the place where if we don't know, then we're just like, okay, we're just going to continue to watch. And bleeding isn't a death sentence for the pregnancy. And it also isn't always meaning that everything's okay either. So it's like, we just have to hold both of those, and it's hard. I mean, this is crazy. Life is hard. It's crazy. It's like really crazy. But thank you for sharing all of that. I feel like it's such a service to women to know these things and to help them, because it can be a scary time.
Okay, wait, really quick. Last thing I wanted to just say is that sort of a general tenet would be like, when do I need to go and seek like help right away? Would be, that one-sided pain, which could be ectopic, or if the bleeding is so heavy that you're feeling a pad like every hour, or there's big clots, you're having a lot of bleeding, you need to go be seen. You can't be waiting till your next OB appointment, which is in whoever knows how long. Also, listening to your motherly intuition. Like, if you just feel like something is wrong and off, and maybe you're having some bleeding and a little bit of pain, and you're like, I don't know what is happening, but maybe you're catching it very early. Like, listen to that little voice inside of you, because we know more than we think.
Yeah. Yep. I love that. Thank you, Dr. Morgan.
Thank you. Are you pregnant or trying to conceive and looking for reliable, engaging education around how to have a healthy pregnancy and prepare for the future aspects of motherhood to come, like birth, breastfeeding, and postpartum? Well, then look, I've got you. This is exactly the education that you'll receive with my 6-week pregnancy call. You get access to my most comprehensive resource of everything I wish women knew before heading into motherhood. It's simultaneously a pregnancy health course, birth prep series, breastfeeding 101 course, and postpartum planning class all in one. And now it's available not only during our live rounds, where you get tons of one-on-one support from me and a small group of like-minded women, but also in a lessons-only format. The lessons-only version of this course is just that. It's all of the content, but it's without the Q&A calls and without the group chat. This version is available on my website at all times too. So log on to www.milkmedicine.com/lessonsonly to check it out, or you can go to the show notes for the link. I hope that you'll enjoy it. Thanks for listening to this episode of the Healthy as a Mother podcast. In order for others to hear this information, please leave a review with Apple Podcasts, subscribe, and send to a friend who could benefit from this content. We're so excited to share more on becoming and being a mother next time.
And please remember that the ideas and views of this podcast are for informational purposes only and are not intended to serve as a substitute for medical care of any kind, including the diagnosis or treatment of any illness or disease. Consult with your provider before integrating this information into your own care plan. And remember, a healthier future starts now, and it starts with you.